Welcome everyone to today's webinar, Maximizing the Power of Relationships, Taking Care of Ourselves and Others. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 1 hour. There will be 45 minutes of presentation, followed by 10 minutes question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listening-only mode, but can interact with the speakers and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. We will also be polling the audience during this session, and we hope you'll participate in this measurement tool. As you exit the webinar, you will receive an electronic survey that we ask you to take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it's my pleasure to introduce my colleague and our speaker for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Beth develops programs to strengthen patient-caregiver relationships, speaks nationally and internationally about compassion, effective communication, and relationships in healthcare, and leads the Schwartz Center's education and research efforts. Welcome, Beth.
Thank you, Lynn. Thank you very much, all of you, really, for joining us as we launch our 2016 webinar series on compassionate collaborative care, or what we're calling the Triple C. During this webinar, I'll introduce a framework of skills to put compassionate collaborative care into your practice. I'll explain how these skills enable us to relate to and communicate more effectively with others. I'll summarize some really interesting recent developments in the science of compassion, and finally discuss systemic issues and potential implementation strategies. The Compassionate Collaborative Care, or the Triple C framework, was developed by the Schwartz Center for Compassionate Healthcare and the Arnold P. Gold Foundation in collaboration with the Hosea Macy Jr. Foundation and the Bucksbaum Institute for Clinical Excellence at the University of Chicago. The complete Triple C framework is available on our websites and the websites of our partners. Each of our upcoming Schwartz Center 2016 webinars will focus on one particular aspect of the framework. So let me begin by telling you a true story. We'll move to the next slide. This is a true story. The emergency room team was ready to receive a young girl who had collapsed on a nearby school athletic field, but they were unable to resuscitate her. The emergency room physician, who herself had just returned from maternity leave, gazed at the child's body in sheer disbelief. The mom arrived shortly afterwards, and her piercing wails gripped everyone who could hear them. One of the nurses led the mother into a conference room where they were met by a social worker and a chaplain, and patients in the waiting room heard the receptionist apologizing for the delay, and they said to a person, "Please take care of that family first. We can wait." One of the members of the code team tried to comfort the ER physician before she turned to the next patient, and the next patient, and the next patient, as you all do, as we all do. But in that brief moment, everyone, including those in the waiting room, became members of a caring community. Why did that happen? I will tell you, it is because compassion is a universal response to distress and suffering. We are hardwired to experience compassion and to offer to help. It's probably how the human species has survived. But the cultures and the organizations that we live in can dampen and sometimes extinguish our compassion. Now, why is this important? Sometimes I wonder why we have to prove that compassion is important, but for those who seek it, there is some evidence. And the studies I'm going to talk about, just a few on this slide, are those in which instruments designed to measure compassion and empathy have been used rather than just communication skills instruments. So we know that first bullet, work by Mager and colleagues, that those who rate their clinicians as being more caring have better psychological adjustment after a cancer diagnosis. In the study by Mack and colleagues, a strong therapeutic alliance was associated with emotional acceptance of a terminal illness and decreased ICU care at the end of life amongst patients with advanced cancer. Interesting work by Raquel and colleagues have shown that the rate of rise of immune system mediators is brisker amongst those patients who rate their physicians as having higher levels of empathy, and they have shorter durations of common cold. And then finally, work by Hojat and colleagues have shown that patients whose physician rate their own empathy and compassion higher have better control of diabetes and fewer hospitalizations for serious complications of this disease like diabetic ketoacidosis and hyperosmolar coma. A couple of years ago, the Schwartz Center for Compassionate Healthcare did a national survey, random digit dialing of over 10,000 cell and landlines to access a representative sample of the U.S. population of physicians who admit patients to hospitals. We asked them whether they thought effective communication and emotional support was important. And of course, the vast majority of both groups said yes. And then we asked them, does the United States healthcare system provide compassionate care? So I'd like to go to the poll because I'd like you to respond to this question. Does the United States healthcare system provide compassionate care? Lynn, can you moderate?
Yes. So, thank you, Beth. Yes, so if our participants could use their polling tool, answer the question, does the U.S. healthcare system provide compassionate care? And the poll is open. Let me see what the results are. Give it a second. Again, the question is, does the U.S. healthcare system provide compassionate care, yes or no? And we've got a good responses. We can close the poll. And Beth, what do you think?
Well, that's interesting. So 53% said yes, 47% said no. Let's go back to the next slide, and I'll show you what our sample said. In our sample, nearly half of the patients and 42% of the physicians said no. The U.S. healthcare system is not providing compassionate care. And then we asked them, does most healthcare professionals provide compassionate care? So let's see how you respond to this. Lynn?
Okay, so if our participants could help us here, do most healthcare professionals provide compassionate care? And we're getting a good response here. Give it another minute. Yes is the first item. The second item is no, and that's got a good set of results. We can close the poll and put up our results. And Beth, what do you think?
Wow, that's really interesting. Let's go back to our sample into the next slide. Here we go. In our sample, again, 46% of patients and 22% of physicians said no to this question. So a little different from what our participants seem to think, but it's interesting. Yeah, go ahead, Lynn.
So Beth, just wanted to comment that in the second poll, the first poll, actually the numbers are fairly consistent, depending on whether we think of ourselves as physicians or patients. But our poll comes back with no, 23%. So thinking that most of our participants are probably medical professionals, not so far off from the study that the Schwartz Center did.
Well, that's interesting, too. But I want to point out the disconnect because there's a disconnect between what patients feel they're receiving and at least what physicians believe that they are providing. So what is compassionate collaborative care, the triple C? It is working interdependently to recognize and respond to concerns, distress, pain, and suffering. I want to make a couple of really important points here. First, that the compassionate collaborative framework is a set of values and behaviors surrounding not only how we treat patients and families, but also how physicians, nurses, every member of the healthcare team treats each other ideally. Second, leadership that demonstrates compassion and collaboration is absolutely critical in setting cultural expectations and in allocating necessary resources to make it possible. And third, that compassion and collaboration is not something that we reserve for end of life. It is how we aspire to treat people all the time, every time. So as we go to the next slide, I'd like to respond to this dilemma. I'm often asked what distinguishes compassion from empathy and sympathy, and I like this cartoon. It's from a text by Mohammad Reza Hojat. He's an empathy researcher at Jefferson University, and he describes empathy really as primarily a cognitive process. It's about feeling as another, walking in their shoes. Sympathy falls more on the emotional side of the spectrum, feeling sorry for another. And there, in that sweet spot between cognition and emotion, empathy and sympathy is compassion, which is feeling with another, walking alongside, not in their shoes, and also acting to relieve suffering. We know that the challenges can be daunting. There is just tremendous workload, complexity of the work, and staffing that may not be sufficient to the task. Burgeoning documentation, regulatory requirements, there's discontinuity, fragmentation of care. Sometimes our values do not agree with those of the organization or the administration or a patient or a family or another team member. I think there's loss of autonomy, loss of sense of control. Staff input may not be elicited or acted upon. And there's loss of community. I feel that we're increasingly living in electronic silos, and then, of course, the ubiquitous time pressure. So the challenges can be daunting. And we know that systemic problems require systemic solutions. We have identified these 7 key drivers of compassionate collaborative care. So during this webinar, I'm going to focus first on the triple C skills framework and later on some of the systemic issues we're going to need to address in order to facilitate its implementation. So this is a visual picture of the model behind the framework, and I've drawn it linearly, but each component of this model influences all of the others in an organic and iterative fashion. I'm going to walk you through the model components. This is the Compassionate Collaborative Framework. It's encapsulated in a very brief table. I would encourage you to download the full framework. It is much more detailed and it's available on our website. So you'll see that the first step in this framework is really paying attention. In order to experience compassion, you have to be able to notice that someone's upset. And this little crayon drawing by a 7-year-old girl says it all. She's sitting on the exam table. And in the room is her mom, her sister. They're packing away at his computer. With his back to her is her pediatrician, who was so shocked when he saw this drawing that he wrote an essay about the impact of technology and electronic health records on the doctor-patient relationship. And this was published in the Journal of the American Medical Association. There is no doubt that the digitization of healthcare, I'm going to go back one, holds tremendous promise, but there's also no doubt that it will fundamentally change how we think, how we communicate, and how we relate to each other as human beings in ways that we really can't conceptualize at this point of time. So to be compassionate, again, you have to be able to notice that someone is upset, and it's tough to focus our attention with all the distractions. But when we do focus our full attention on the patient or even a coworker, it initiates a process of human connection that all by itself can be healing, and not just for the patient, but for us too. Focusing our attention requires us to consciously set aside all the tasks, all the chatter in our minds, so that we can notice and perceive the patient or a colleague's distress. And I use something I call the doorknob strategy, which I've taught to people on several occasions. Before I'll enter an exam room, a hospital room, or any important meeting, I'll put my hand on a doorknob or some other equivalent, and in a disciplined way, consciously set aside all the tasks inside my brain so that when I cross that threshold, I really can fully receive the person on the other side of that door. So we begin with mindful focusing of attention. Now, we teach communication skills to students, to residents. These are the efferent output loop of interactions that we usually teach, but we don't teach them the afferent input loop skills, which are active listening and learning to accurately interpret facial expressions of emotion or nonverbal behavior. But a colleague, Helen Reese, has been working on this. She is a psychiatrist and a researcher at Mass General Hospital, and this is data from a randomized control trial she did with her house staff in different disciplines at Mass General. And in addition to teaching them some of the science of empathy, she taught them how to accurately decode facial expressions of emotion using a protocol developed by Paul Ekman, a very well-known psychologist. And what she found was that the intervention residents scored higher on tests of this skill, and the patients in their clinics actually rated their empathy higher than the control residents. So this shows, I think, that the components of this framework are teachable and learnable, and they have impact, perceptible impact among patients. We'll go to the next slide. Well, whether we are perceiving pain in another or experiencing it ourselves, we activate these overlapping neural networks in the brain. This is an automatic bottom-up phenomenon. It happens in the oldest parts of the brain. Some people call it experience sharing or affective empathy, and then within milliseconds, the parts of the brain associated with cognitive processing of what we are witnessing kick in. And some call this process, it's a top-down process, mentalizing or cognitive empathy. It's about trying to understand the other person's experience. And these processes are mediated by a whole host of other factors that include trait empathy. After all, we're not all empathic to the same degree. Repetitive exposure to other people's pains. There's been interesting work by Jean Dessetti at the University of Chicago showing that physicians and acupuncturists, actually, others have studied this, actually downregulate their empathic responses to pain after repetitive exposure, an adaptive phenomenon. There's perspective taking, whose perspective we take, the ability to regulate our emotions, and of course the culture or the context within which we are observing that other person's pain. So let's talk a little bit about perspective taking. You know, we're often taught to practice empathy by imagining ourselves in someone else's shoes, but the perspective we take really influences our responses to other people's pain. So in this study by Lown and colleagues, participants were told they were going to see some video clips of patients experiencing painful auditory stimulation that was being used as a medical treatment. And before each video, they were instructed to either imagine themselves in this painful situation or to imagine the other person in this situation. And what they found was that the imagined self instructions led to more personal distress. As you can see in this figure, the imagined other led to more empathic concern. And these activated different areas of the brain on functional MRI imaging. So it may be that if you are practicing empathy or teaching it by telling people to walk in someone else's shoes, it may be time to change your shoes. So we can talk about this. You know, what we really need to talk about, though, is emotion regulation. I think that students, trainees, people who are new to practice are really unprepared for the suffering that they witness. And this is something we really need to tend to because it is really a direct contributor to personal distress and burnout. So I'm going to talk about two different ways of approaching emotion regulation. The first is cognitive reappraisal. And let me illustrate this with a story. I had taken care of a woman for several years before she developed a cancer requiring chemotherapy, radiation, multiple surgeries. She had several children, and among them her youngest daughter wanted everything to be done, feeding tube, full code, even though her mother's wishes were to the contrary of this. The patient did die, and I was thinking about her a lot because I actually really loved this woman. She was just gentle and humble, generous and kind. And then I got a call from her daughter. She wanted to come and see me. She wanted to bring her dad with her, and she was very, very angry. She wanted to know why I hadn't done more, why I hadn't been more aggressive earlier in her mom's course. I was at first surprised, then I got defensive, and then I got angry. I felt that I had really done my best by this woman. So I got prepared, and then the day of the meeting, I was out of the office for a bit, and my practice partner called and said that she had canceled the appointment. I said, well, what do you think was going on? And he said, you know, I think she just wanted to be reassured that she had done all she could, that she'd been a good enough daughter. And that brief insight just dissolved my anger. It restored my compassion. I could really relate to this young woman. That is cognitive reappraisal. It's all about attaching new meaning to events and experiences. The problem is it's really hard to do on your own. You could perhaps do it with help or in reflective groups. The other problem is that it's done after the fact, after the emotion has set in, and so sometimes it can be hard to reel it back in. So another approach is secular meditation or mindfulness training, which has gotten a lot of press lately. This is another approach to emotional regulation that seems to reset internal responsivity to emotional distress, and it enhances affect tolerance. So let's take a look at this in more detail. I'm going to show you a study. I'm usually asked, is this really something you can train people in? I mean, aren't you just born either compassionate or not, or empathetic or not? I'd say we're just now seeing evidence that these qualities actually are trainable, and training in empathy, as it's phrased here, and training in compassion actually have very different impacts. So this diagram's from a study by Olga Klemecki and Tanya Singer and colleagues at the Max Planck Institute in Germany, and they compared the impact of an affect group training to memory group training. So in the affect group, they had a one-day training in empathy followed by one-day training in compassion, and the memory training was going alongside as an active control. So both the empathy and the compassion trainings involved some didactics on emotion theory and then instruction and 15-minute practice sessions. In the empathy group, they were instructed to resonate first with one's own and then with the suffering of others, extending from self to more distant people, loving loved ones, and then more distant people. And in the compassion group, and on the contrary, they were asked to visualize their own past suffering and then to cultivate feelings of loving kindness towards oneself and then others' suffering. Here's what they saw. They found that empathy training increased self-reported empathy, of course, but it also increased negative emotions in response to videos of suffering, as well as to videos of just everyday life. The empathy trainees had increased activations in this part of the old part of the brain called the insula and the cingulate cortex. This is the empathy for pain network, and it has also been associated with feelings of social disconnection. The compassion training actually reversed these effects. It returned negative affect to baseline and strengthened positive feelings in response to these videotapes of suffering in everyday life. And the neural networks were different. It was the medial orbital frontal cortex and striatum. These are areas that have been typically associated with reward and social connection. One more study. So this is by Jensen and colleagues. This is the only study I know about in which they actually put physicians inside of functional MRI scanners, and they gave them instructions to push a button to either fully or incompletely relieve the pain of an experimental subject that they could see outside the scanner. And of course, not surprisingly, the physicians felt more satisfied when they believed they had fully relieved the patient's pain, but the areas of the brain that lit up were including striatum, part of the compassion network that I just mentioned, which we know is a key region for dopamine-related reward processing. Bottom line, compassion makes us feel good. It makes us feel a sense of reward, of connection, and a sense of purpose. So by way of summary, there appear to be two different neural networks, one involved in empathy for pain and another involved in compassion. And these and other studies suggest that we may respond to pain and suffering with compassion or personal distress or some mix of both. Personal distress is a self-focused, it's kind of an aversive reaction that makes us want to detach, to withdraw, to avoid. So the implications for me are that we should be learning, practicing, teaching all of the skills in the CCC framework, including emotion regulation strategies, because people who experience compassion are motivated to help. And people who experience personal distress may be more likely to detach, to depersonalize others, and to burn out. Okay, so far I've just been discussing preparation for compassion. So obviously we need good communication skills to understand the specific concerns of a particular individual. Everyone is different and unique. There are many wonderful toolboxes of communication skills that can help you with this, including questions to elicit the patient's explanation of illness. I'll refer you to this classic article from the late 70s by Arthur Kleinman and colleagues in the Annals of Internal Medicine, referenced below in the footnotes. And also, I'd like to bring up this notion of resurrecting the psychosocial context, the psychosocial review of symptoms and systems. The social history used to reflect who the patient was as a person in the context of his or her life. You know, access to care, financial constraints, who's at home, who are your supports, how do you get to the clinic, can you get to the clinic? If we don't understand these issues, we're more likely to come up with care plans that patients just simply can't implement. So there are some people who are looking at this anew, and I refer you to the book by Weiner and Schwartz, again listed in the footnotes. In fact, some of these questions and issues could be recorded in the electronic medical record. Perhaps that would actually add personal meaning to electronic records. I want to also point out this new program that is being created by Rachel Bernanke, Susan Block, Atul Gawande, and others. They've created something called the Serious Illness Care Program. It involves a series of questions to ask patients about their concerns and values, and it's embedded in the electronic medical record. It can be continuously updated. Their program also includes some interactive sessions for clinicians to learn how to have these conversations, and their randomized control trials underway now. So this is another way to make meaningful use actually more meaningful. Okay, there's one more element involved before we get to experiencing empathic concern and compassion. In order to experience compassion, we actually have to value the person's welfare. We have to care about that person. And this can be significantly diminished by unconscious assumptions, stereotypes, and bias. I remember once a while ago making rounds with a team on a young man with sickle cell crisis. I asked how they were managing his pain, and one person said, "Oh, they're all just drug seekers." I was taken aback. Maybe this was one person's response, but we know very well that in the very conditions we practice in, high volume, time pressure, complexity, uncertainty, physicians use cognitive shortcuts called heuristics to make decisions. And these can lead to errors and the suspension of compassion and to the perpetuation of healthcare disparities. So we finally arrived at empathic concern and compassion, but it's not enough to feel it. You actually have to show it in response to others. I like to teach something, a little toolbox. We call it the RSVP skills. The R stands for reflect what you see or hear. You look upset. S stands for support. I'll be here to help you. V stands for validation. It's understandable that you're feeling this way. You're not alone. And P stands for partnership. We'll do this together. Whatever you say, it can't be scripted. It has to be authentic, and it has to come from the heart. And lastly, perhaps the most complex skill that we don't teach enough, and we know from research we don't do very well, is informed decision-making, which really requires the integration of the experience, the wisdom of the clinical team, and the wisdom of the patient and the family, their experiences, their values, their goals, their priorities, and their preferences. So again, let me illustrate this with yet another story. And this, again, is a true story. I met a woman who had this immune disorder, had really compromised her lung function, and she was in the hospital 6 times in 8 months in ICU on a ventilator, and she felt that everything she loved and valued had just been stripped away from her. So she was a young woman, but she decided to refuse intubation the next time she wound up in an emergency room. That's exactly what happened. The emergency room staff tried to persuade her to change her mind. They all descended. "You're young, we can save you." But she was very certain about what she wanted, until a critical care doc came down to speak with her, and he heard her say, "I can't face it again." And instead of telling her all the reasons why she should let them intubate her, he just said, "What is it you can't face? Tell me what we could do differently." These are her words. "The restraints, I feel like an animal. They tell me I have to be restrained because I'm agitated, but I'm trying to get free." He assured me he wouldn't allow me to be restrained. He told me he would stay with me till I was stable and calm. If he had to leave, he'd leave explicit orders to call him if I became restless. No one would have permission to restrain me. And the morphine, I don't want to be doped up all the time. I need to be able to ask for it when I need it. Sometimes it's more important for me to be alert so I don't slip away into the rhythm of that machine, breathing in and out, in and out. He showed me the order as he wrote a PRN order for morphine. Our conversation couldn't have taken more than 5 minutes, but it was a powerful force. I could feel myself slipping into the dreaminess that would end my life if I refused the ventilator. Literally, this man stood between me and death. He took my hands and looked at me and said, "I don't want you to die. In a few minutes, you'll be unconscious, but I won't do this if you say no. We can work together on this." As it turned out, this young woman agreed. She went into remission. She told me the story some 20 years later. There are so many remarkable aspects to this story. It always strikes me that together, these two human beings created a pathway forward that neither one of them alone could possibly have imagined. This is what I would call transformative, compassionate, collaborative care. Our ability to engage in this vital process depends strongly on the well-being of each and every one of us, because we simply cannot experience compassion, let alone offer it to others, if we ourselves are depleted. You probably know these statistics, but 40 to 60% of nurses are burnt out, and this has increased by 10% in only 2 years. Work-life satisfaction is decreasing significantly among physicians, and the rate of physician suicide is significantly greater than that of the general population. But take a look at this bar graph. This was from a 2010 workforce study, and this firm found that in the United States, less than half of the surveyed healthcare employees felt that their leaders were sincerely interested in employee well-being, and this has been confirmed by a 2014 study of the American College of Healthcare Executives. Employee well-being did not make it on the top 10 lists of CEOs' concerns. But it has long been known in the business world that employee satisfaction drives customer satisfaction. So take a look at this study by Laura McClellan and Tim Voges. They surveyed a random sample of HR vice presidents and COOs or CEOs of acute care hospitals using their compassion practices scale. It has 5 questions. To what extent does your hospital use recognition programs for acknowledging employees' acts of caring shown to patients and families, for helping one another, compassionate caregiver awards, regular counseling programs, and support sessions for departments or units dealing with crises, conflict, trauma, workplace stress? And what they found was that, go back, there we go, that the compassion practices remain positive and significantly associated with the patient's perceptions of care, the HCAHPS ratings, and the likelihood to recommend the hospital. This is really important information. And by the way, they mentioned Schwartz Center Rounds as a method of supporting caregivers. Just by way of reminder, in our study of the impact of the rounds amongst attendees, we found that frequency of attendance was significantly correlated with increased feelings of support and decreased feelings of stress and isolation. And we also found that frequency of attendance was correlated with appreciation of co-workers' roles, a key foundation of collaboration, also better communication and teamwork compared with less frequent attenders. The Schwartz Center convened a meeting a couple of years ago, and Harvey Feinberg was our keynote speaker. He's the former president of the Institute of Medicine. And he said, compassionate organizations start with compassionate people. But the greatest inhibitor to individual caregivers showing compassion is that they themselves are disrespected, under stress, and not permitted to express their full professional engagement and responsibility. So what has to be done to make it possible to offer compassion and collaboration to patients, to families, to team members, amongst ourselves, and to coworkers, and to be supported by leaders and managers in this work? We believe that key drivers to systemic solutions include compassionate leadership, valuing and rewarding compassionate collaborative care, education, supporting caregivers to prevent burnout, prioritizing compassion, collaboration, and quality improvement initiatives, involving learning from patients about how best to do this work, and also research and measurement. So let us reconsider the value equation shown on the next slide. Can we study the value, maybe even the return of investment, on time spent with a distressed patient or a family with complex needs? How about addressing professional dissatisfaction and burnout? What is the value of factoring time and capacity for compassion and collaboration into staffing ratios? And how could we apply this value equation, really looking at the benefits of cost, to a balanced approach to patient throughput that honors not only patients' and families' needs, but also team needs, clinicians' needs, caregiver needs? If we did this, how would we measure the value of compassionate collaborative care? Could we measure the impact on health outcomes, readmissions, costs of care, burnout, physician suicide, patients' perceptions of care coordination, and a holistic approach to their needs, and patient and professional satisfaction. The measures that we currently use to assess patients' experiences of care, such as the CAP surveys, they don't really fully capture these interpersonal aspects of care that are important to all of us. The Schwartz Center has developed, and we're continuing to test the Schwartz Center Compassionate Care Scale in two ways, both as a professional self-report instrument and with patients in various settings as a patient-reported outcome measure. Stay tuned for this. We're continuing to work with patient partners on this. There are several key venues in which we believe we could integrate the CCC framework. One is certainly in quality improvement initiatives as part of team training within or across departments or units among groups working on some of the thorny quality improvement issues. Just imagine, for example, team training in the CCC framework for members of an emergency department and an inpatient team working on flow issues. Perhaps these skills, learning to relate more effectively to each other, to patients, to families, to all members of the team, would actually improve how the members of the team related to each other and to patients and families in their efforts to improve flow problems. Secondly, we should integrate the CCC framework in competencies for undergraduate students and postgraduate trainees across the professions, and especially in opportunities for interprofessional education across the continuum of learning. This could potentially be assessed at various assessment points, such as the United States Medical Licensing Exam, which involves assessing students interacting with standardized patients in the second step of this licensure process, and in other assessment processes across different professions. And finally, we think that initiatives that involve patients and families in co-designing both health professional education and how we deliver care would be another venue for incorporating, teaching, and assessing the impact of the CCC, and it would also model what we're hoping to see in the world. We discussed this last bullet point in an article in Academic Medicine that was just published on Monday. I've referenced it below. So the key questions, I think, to ask ourselves are, what really matters to you? What is our collective and individual responsibility for preserving compassion and collaboration in healthcare? And I'll ask you to ask yourself, what is my role in this process? If you believe that these values, these behaviors are important, that they are the foundation of what we went into healthcare to do, I'd invite you to please take a closer look at the framework. Let us know your thoughts. Let us know what you're working on. Tune into the 2016 webinars. Give us some feedback. And let's develop a community of practice around compassionate collaborative care, the CCC. Thank you. Let me see if there's some questions from the audience. Lynn?
Beth, thank you so much for sharing your insights. This is an amazingly rich presentation and area for further discussion. We have a number of folks who've asked us if the handouts and the webinar will be available on our website, and the answer is yes. You can hear Beth. We'll have this up on our website in about a week, and we will also include the slides and a handout of the slides. So hang in there. And there's a lot of material that Beth has presented for us. We have a number of questions, but before we begin, I just want to remind our audience, if you have a question, you may still do so. Just type your questions into the questions pane, and we'll answer as many as we can in the remaining time. And Beth, you just worked through that. It was wonderful. So our first question is, what are the risks associated with compassionate care? Can you think of anything that, why not do this?
Yeah, well, it's a great question, and the answer may seem obvious, but it's actually complicated. I'd say the risks to the individual, again, unless you're aware of all the skills in the framework, unless you're self-reflective, you're able and you have access to colleagues with whom you can discuss some of your challenges, it's easy to experience personal distress. And that, as I've discussed, can lead to detachment, to burnout, to wanting to avoid this, or to cynicism. So I would say that having a community around you of colleagues with whom you can reflect about the challenges of everyday care, including the Schwartz Center Rounds, by the way, that it can be problematic. It can be risky to fully expose yourself. And I want to point out again, this notion of emotion regulation, this is something I was not taught. It's sort of, it's kind of obvious, but it's a late discovery for me. If we don't learn these strategies that are helpful to us, not stuffing our emotions under the rug where we never deal with them and then, we suffer the consequences and our patients and their families suffer the consequences. We need to learn these strategies to get coaching, to have some kind of training in emotion regulation, whatever your preference, whatever the style, so we know how to experience them without being overwhelmed.
Very, very good, Beth. And what I'm hearing is, one, get some training, but two is get a partner, get a community around you to help you, because it really is hard to do alone.
Absolutely.
Excellent. Okay, so in the front end, what are the first seeds an employee can sow to begin to increase compassion in a hospital setting?
I actually think it's the first thing in the model. I think we need to learn how to settle ourselves, how to become settled, how to focus our attention on the person that we're about to encounter. It has to begin actually before we begin an interaction. And again, I think it requires consciously setting aside the distractions that we all have. We have these personal devices, the exam room and the computer. There's a million distractions. I think the first step is learning how to get ourselves centered, focused, calm, so that we can actually offer our full attention to the person that we need to interact with.
Excellent. Wonderful. And Beth, can you remind us what the RSVP stands for again?
Yep. The R stands for reflect. You're a mirror. You're going to hold up the mirror of what you have perceived to the patient. The trickiest part about this is not asking a question. Just reflect what you have seen or what you have heard or what you have felt, but more likely what you've seen or heard. I hear the frustration in your voice. I can see by the slump in the shoulders that you're feeling just down or helpless. Help me understand, Asking a question means that you're taking over control of the conversation, whereas if you just reflect what you've seen, the patient gets to go deeper and to really tell you what they're experiencing. So just reflect, be the mirror. Don't ask questions just for a couple of minutes, maybe even just a couple of seconds. Okay, that's the R. The S is support. I'm here. This is how you get a hold of me. I'm here to be helpful. Support, S. V, validate the feelings. You never say, I understand how you're feeling. You don't understand how they're feeling. You can say, I can only imagine how you might be feeling. Or, it's understandable that you would be feeling this way. Other patients that I've had have expressed similar feelings to me. Validate the emotions. And then P is partnership. We'll work on this together. If you remember, that was actually the last piece. It was the last sentence in the vignette that I recounted in the words of the patient who agreed to be intubated. We'll work on this together. That's what changed her mind.
Yep, I'm here with you. We're going to do this together. Wonderful. Okay, we rewrote our educational vision and mission around the Triple C, adding a fourth C, competence. What do you think of this addition, and how do we build a program around it, maybe? Some suggestions, I guess.
Well, competence is quite a loaded word, and it depends a lot on, what setting this is. So those out there may or may not know that health professional education has moved from a time spent on something to a competent demonstration of, a value or a behavior as the metric for moving on in one's education and training. And there's been a lot of work done on trying to articulate what the competencies should be. But the fact of the matter is, you can be nice, but if you don't know what you're doing, it's not going to help very much, you know. So competence, however defined, in undergraduate medical education, we have what are called the entrustable professional activities that have been articulated by the Association of American Medical Colleges. The nurses have their own essentials document. All of this is actually outlined in our recent academic medicine article. And in that article, you'll find that the CCC framework is mapped onto the competences, some of the competencies, and the entrustable professional activities. So yes, we have to integrate this framework with ongoing work, and the competencies that are being articulated is absolutely essential. They're not meant, though, to be an add-on. You'll see that many of these are represented in some way or fashion in some of the already defined competencies, like communication skills. I spoke about that a lot during the presentation. In what's called professionalism. So they're represented by different words. The key is expanding the competencies to represent what is now underrepresented in our teaching. And that is things like, you know, centering yourself, many moments of mindfulness, the emotion regulation, the self-reflection, the finding a community of practice. You'll see it if you review the CCC framework.
Very helpful. And again, that reference will be on the slides when we put them up on the website. Great. Thank you. And I love your concept of integration as well. Let's see. A couple more. I'm particularly interested in applications to hospice, palliative care, and home care staff members. Can you give me some advice?
Well, the CCC framework is ideal as a training framework in those settings, as it is in all settings. You know, I mentioned at the beginning, this is not something we reserve for end-of-life care. This is all the time, every touch point of care, whenever someone or a patient or a colleague or a family member is distressed. But in particular, in hospice and palliative care, in long-term care, when you're treating the very ill, people with life-limiting illness, the very vulnerable, the frail. This is exactly where this framework is important. So I'd encourage you to think about it and how to use it as a training framework. And again, you can download it from our website because the actual document has detailed behavioral descriptors for each of those bulleted elements of the framework that I showed in that abbreviated table.
Very helpful. Good. Okay. What is the state-of-the-art and best practices for self-compassion for healthcare providers promoted by healthcare organizational leadership?
Well, that's a double-barreled question in a way. I mean, first of all, what is best practice in self-compassion is one thing, and you know what is being promoted by leadership is sort of another. But I really I really like the work of Laura McClellan and Tim Voges and their compassion practices scale. If you take a look again at the slide, that described those 5 key questions, to what extent does your organizational leadership endorse and put into play these recognition programs for employees showing compassion and caring to patients and families, to each other, provide counseling, and provide support sessions like the Schwartz Center Rounds, by the way, for units or departments that are in distress or suffering from conflict or stressful work-life situations. So those are some of the practices that have been endorsed, and some are practicing them.
Well, and as we've talked about, this commitment to compassion at the leadership level is critical for engaging in these programs. So, simply making it a priority.
I think so, but I also think recognition is not enough, and I just want to make that clear because it's difficult if the allocation of resources is not balanced. I understand the need to, balance the budget, have reasonable margins for healthcare organizations, but I think it has to be balanced with really putting patients' needs at the center of the equations and the team, the clinicians, the caregivers' needs at the center as well in a balanced fashion. You can only ask people to see so many people per hour, so many people on a panel, so many people nurses tending to patients on a given department ward before it becomes impossible, however, well-intentioned you are. So this is where leadership really has to step in allocating the resources that are really necessary to provide compassion and collaborative care. So,
and I have a specific question that I've just received. What should we do when we feel a disconnect with another clinician who also cares for the same patient?
Well, I mean, it happens a lot, doesn't it? I think the first thing I would say is to hold an open mind and to be curious about the nature of the disconnect, not to assume that you really understand what that other person is thinking or the judgments upon which the disconnect is based. Open, non-judgmental curiosity and inquiry are the way to go. And just asking to open up a dialogue, that's the first step in any situation in which conflict or disagreement exists. And, that kind of open, non-judgmental curiosity really permits for dialogue. It's a learned skill.
Yeah, that's wonderful. And it's walk the talk. You have to do it for patients. You do it with your colleagues. You do it with yourself. Could you say more about the serious illness care as part of the electronic record, which you referenced in your talk?
Yeah, it's very early on, and I can't say much about it, but there was a publication that is available that I referenced. It's online, and I believe it was BMC Open, if I'm remembering correctly. So you could access that. It's just a description of the program the lead author is Rachel Bernanke. So the program is just underway. It's just being piloted. It's just being tested. They are running a randomized control trial on it.
Excellent. Thank you. Beth, I know you apply this to all situations, not just end of life, but what impact do you think the new CMS code for end of life discussions will have on compassion?
I think it's terrific. I think it's absolutely terrific. The sad part is that we have to reimburse people to provide time for them to have these conversations, but it doesn't matter. As long as they're happening, I think it's a first step in the right direction. For too long, we have not discussed the very difficult issues of what people really want. And I think, as a physician, I think these are hard conversations to have. And, it's partly because we don't want to imagine a bad outcome for our patients. And so we tend to sort of not want to talk about it. I think also we kind of think, well, if we bring up the subject, people are going to think that we're harbingers of doom, and that will create a self-fulfilling prophecy. This was found by Nicholas Christakis. He wrote a book on prognostication. But in truth, if we don't talk about it, people will get what they do not want. We know that people don't want to die in the hospital. We know that given a lot of information, people choose different things. They may not choose invasive procedures, even surgeries, back surgery and things like that. It doesn't even have to be end of life. But having these conversations, I think, opens the path to get back, or maybe for the first time, to really engage with patients, with family members, about what they truly want for themselves. What do they really want? What are their main concerns? What are their fears? Those are the things that we need to be talking about. We're not holding our end of responsibility if we don't talk with patients and families. And you know what? We should be talking about this with our own families. There are lots of wonderful conversation guides out there to initiate conversation with your own family. In fact, I think if you start to have a conversation with your own family, you're more likely to feel comfortable trying to do it with patients.
That's a great back around at you recommendation, Beth. Was excellent. Thank you. Could the Schwartz Center for Compassion Care enter the mental health field?
Well, we don't exactly exclude them. For example, the Schwartz Center Rounds are offered in facilities that are devoted to mental health and psychiatry and the like. We're there.
Yes, well, and I was going to say, we have a number of members who are in the mental health arena, so thank you for answering that one. I think we have time for one more question. Let's see. We've got quite a few. Let's see. What does a quality debrief following a stressful situation include?
Again, of course, it depends on the situation, the setting, the context, what happened, et cetera, et cetera. But I think I don't want to sound like I'm going to give you an algorithm, because whatever you create in your well-intentioned purpose for this, hopefully it's about learning. Because, a just culture, as they call it, is a compassionate culture, and the goal is to learn from whatever it was that happened. So that's the first thing, to explain that, to set the ground rules about it. I think, again, it's all about let's hear your perceptions of what occurred. What did you see? What did you experience? What did you feel? And I think, the thing that is not necessarily included in a debrief is the emotional impact of whatever it was that happened. So I think, there's a lot to be said about that, and I think I just want to stress those key points, that you start by creating a community that is hopefully there to learn together. And that you include the emotional impact of the event that occurred. Super important.
Excellent. That's fantastic. I think we are now at our close for the time. Wraps up our Q&A session. But Beth, any final thoughts you'd like to share with our participants?
I would just say that if you have more questions, just email us, and please download the framework. Let us know what you're doing. Give us some feedback. Tune into the webinars. The upcoming webinars are listed here. And I want to make one more point. These are all on our website, so you don't have to write this down or anything. But I want to make one more point, and that is that we are, go back. Okay. We are we are creating a continuing education course. It's an interprofessional course, not just for doctors, but it is being offered through Harvard Medical School continuing education. And we are going to have some just outstanding speakers who are just experts in the neuroscience of compassion and empathy, and a lot of fantastic interactive workshops. So please save the date, and we will have some more information in the near future on our website.
Great. Beth, thank you so much. And I'd like to thank you for sharing your expertise and insights with us, as well as everyone in the audience for setting aside time in your day to participate. We hope you'll join us again for upcoming webinars. We're having them monthly this year, so a lot's coming around faster than they did a year ago. We know you're busy. We very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, as we truly value your input. And we want to thank you and have a fantastic day. Beth, you're wonderful. Thank you.
Thank you.